So in the end, we would have a picture together.
Right.
Whose voice is that?
Okay. Yeah, it's the middle.
All right, I think we can start now.
Okay.
Good evening, everyone from Jogja. Now 9 p.m. here in Jogja, Jakarta time, and hope you are doing well wherever you are now. I'm Aziz Anwar, a staff member at the Center for Religious and Cross-Cultural Studies, CRCS at Gajah Mada University. But right now I'm in my village, and perhaps you may hear some noises on my background because people are doing tadarus, Quranic recitation in the mosque beside my house. Welcome to Wednesday Forum. This is a forum that is held by both CRCS, Gajah Mada University, the Graduate School of Gajah Mada University, and as well as the Indonesian Consortium for Religious Studies, ICRS, which is a PhD program of religious studies, also located at the Graduate School of Gajah Mada University. And we have our guest today, who is Professor Christine Kudov. You can say hello.
Hello, everyone.
And she is a professor of religious studies at the Florida International University from 1993 to 2015, when she retired 5 years ago. And she published 9 books and more than 200 journal articles. She was also a chair of ethics section at the American Academy of Religion. She was Fulbright scholar also and was visiting CRCS in Yogyakarta. And tonight, Professor Kudov is going to talk about, well, the title is Ethical Decision Making During the COVID-19 Crisis, and what are the lessons that perhaps we can derive from today's crisis so that we can be more prepared when facing the next pandemic in the future. So usually we have 45 minutes for presentation, for the speaker to do presentation when we are doing this on offline. But since this is online, perhaps around 30 to 40 minutes, that's enough. And then later we can have a discussion. And for the people who are going to ask or who are going to comment, you can do it 3 ways. You can do it by raising your hand, but not physical hand, but virtual hand on the via Zoom, or you can do it via the chat room in the Zoom, or you can do it via our YouTube live streaming. And we have now 51 people here in the Zoom, and most of them, I believe, are Gajah Mada University students, not only CRCS students, but also students from the class that Pak Iqbal teaches at the Faculty of Political and Social Sciences of Gajah Mada University. All right, without further ado, I will give the time for Professor Kudov to presentation. Ladies and gentlemen, please welcome Professor Christine Kudov.
Thank you, Aziz. The first thing I'm going to do is load you up with a lot of facts about COVID-19, things that we are still learning about, because this is a new pandemic and the doctors and public health officials are learning new things every week, as you'll see as I go through. COVID-19 is a coronavirus related to the 2003 SARS coronavirus, and it's now one of the most infectious diseases that we know of. While a typical flu patient will normally infect one other person, a person with COVID-19 typically spreads the virus to 5.5 other persons. This is because the method of spread is most often by coughing, which propels the mucus and saliva of an infected person up to 10 feet to the face and hands of another, or to some surface that they may touch, like doorknobs or handrails. The virus can survive on some surfaces only for 4 or 5 hours, but on some surfaces, such as plastics and metals, it can live for up to 6 days. 6 days. Once infected, some people may only have 24 hours from the beginning of the first cough to needing hospitalization in order to breathe. Other people, slower. While most people will recover from COVID-19 without hospitalization, somewhere between 6 and 10% will need to be hospitalized, either so that they can get supplemental oxygen, or in the most serious cases, they will need ventilators to breathe for them. Once on a vent, that's abbreviated from ventilator, once on a vent, persons will remain on the vent for about 3 weeks, which is one of the reasons why it's so easy to run out of ventilators, because people need them for so long. Once on a vent, after the 3 weeks, people will either recover or they will die. Initially, it was thought that about 5% of infected people will die, even with ventilator assistance. But since then, we have learned that large numbers of infected persons recovered at home with mild cases, and so were not counted in that statistic. The death rate has now been recalculated at 2.5%, still very high. The peak of deaths in every country will occur about 3 weeks after the peak of new cases. For the first months of the pandemic, the initial symptoms were said to be high fevers and coughing, often progressing to an inability to breathe. Now, other symptoms have been added, such as the loss of taste and smell, headaches, and lower fevers. The incubation period between first exposure to the virus and the beginning of the symptoms is from 2 to 14 days. It's a long period. For some people, it will be 14 days before they develop symptoms. For others, only 2. The dangerous part is that once persons are infected, they can infect other people for the same 2 to 14 days before they themselves have any symptoms. For the majority of populations which did not begin testing immediately upon the first deaths, the only way to mitigate the disease is masking and social distancing, including lockdown, which you all know. Masking an infected person can contain 90 to 95% of the expelled virus. But a mask will only offer about 60 to 65% protection to an uninfected person, because the bits of virus that escape, the little bit, the 5%, 5 to 10% that escape from a mask on an infected person will be in the air, on surfaces, whatever. So the mask will not protect an uninfected person from those the virus particles that are around them. Since not everyone has been tested, we don't know who has the virus and could be infecting others. So to protect anyone, everyone must be masked and keep social distance. This is the most dangerous thing about this, that we can spread this virus long before we ever know that we ourselves have it. I sent 2 sheets of stats, which some of you have. One of it lists the numbers of deaths and tests per nation. If you could show that one, Aziz, do you have that? A list of nations with a list
nation.
of the deaths.
All right, I can show it.
Okay.
Is that it, or the other one?
No, it's the other one. The other one.
All right. Which one?
It's a list of countries. Do you see the list of countries? It has a, yes, that's it. Okay, so you see, this is the total number of COVID-19 deaths per million inhabitants and the number of COVID-19 tests per million inhabitants. Now, if you look at the first column, I included this to show you how misleading some statistics can be. Because according to this, South Korea has 5 deaths per million, and India has 0.5 deaths per million. But you can imagine how unlikely it is that South Korea would have 10 times the death rate of India. Now, the reason for this is that South Korea has finished its curve. The first wave is gone. There have been no new cases now for a couple weeks. So they are virtually finished with the first wave. Whereas India is still doubling new cases every 2 to 3 days. So India is just beginning for the curve to go up, whereas South Korea has already come down on the other side. The biggest thing that will predict the death rate in a country is the number of tests per million inhabitants. While it may look here as if the US is in good shape, no, not, because the US has a huge population. And we have tested only a fraction, and many of those tests, for example, the president and everyone around the president gets tested every 2 or 3 days. So some privileged persons have had multiple tests, and the majority of the population has never been tested whatsoever. We still don't have enough tests here. But if we look at South Korea, if you can go to, yeah, South Korea. South Korea has done 17,579 tests per million. And that is not even a huge number. Many countries have done more. But in South Korea's case, they began testing the moment the first case arrived. They developed these tests, put them out by the hundreds of thousands, and they started a routine that we know of as a test, trace, tests, and quarantine. That means the first people who have symptoms, you test. If they are positive, you trace everyone that they have been in contact with for the previous 2 weeks, test all those people. And the positives in that group then they will get traced too. And everyone that is positive goes into quarantine immediately. Because they were so successful at this, at capturing every case, the disease did not spread. They were able to get through the entire wave very quickly. Singapore also, look at their two deaths per million. Singapore, like South Korea, was one of the earliest infected nations. They had a great regime for testing and tracing and testing and quarantining. Very few countries have that good a routine. Germany, I would point out, Germany also did a very good job, although they did not lock down and start testing until a little bit later, but they also have done multiple testings. Now, China, South Korea, and Singapore had all prepared for this pandemic following their experience with SARS. That's why they were the best at containing the virus. In all nations, the death rate shares some similar characteristics. The most, I don't need the sheet anymore. You can take that one down, Aziz.
Okay.
The most vulnerable were those over 50 years old, and more danger is associated with every step above 50. Slightly more than 89% of the dead also had at least one comorbidity. Aziz, if you would put up the other sheet.
Right. The one, this
The
one.
one from New York State.
Yeah.
Okay, and push it up a little bit so we can see the bottom.
This one.
All right, yeah, see here, the top 10 comorbidities of the dead. That's right there. 89% of those who died, regardless of their age, whether they were 1 year old or 90 years old, 89% had at least one of these conditions ahead of time. You see what they are. You can see the numbers. These numbers are from New York State. I use New York State because New York State is the place in the US which is towards the very close to the end of their curve. Their cases have been going down and down for the last week or two, but also because they collect the best statistics. So you see the most common comorbidity was hypertension and diabetes, and it decreases. To go up a little bit, one of the things that we don't expect, but is very interesting, is that the dead by sex. You could go up just a tiny bit more, Aziz. Yeah, a little bit more. I want to see the dead by sex. Okay, see this? Of those testing positive, 47.6% are female and 52% are male. So more males test positive than females. But when we look at the dead, the percentages are, it's about 40-60. We don't know why that is, why more men die. We need more research about this. You see here the ages of the dead too. You can see the percentage. The percentages grow bigger and bigger with the higher with age. Very dangerous.
Yeah.
Okay, you can take it down. I apologize if all these statistics were known to you already, but you really can't talk about ethics without the circumstances in which ethical decisions must be made. The only absolute ethical rule in this pandemic is do not kill. But in order not to kill without intending it, one must consider such statistics. The individual mandate in order not to kill is to mask and observe social distancing. Since no one can know whether they have the virus or not, one must act as if one does have the virus and mask and keep distance to prevent spreading the virus to others. To not mask, to move about in public like normal is to risk endangering the health and life of others. I'm sure you won't be surprised that death rates are not the same across racial, religious, and economic differences. In the sheet on deaths in New York, Blacks and Hispanics have higher death rates than their proportion in the population would predict, and whites have fewer deaths than their proportion of the population would suggest. In Louisiana, a state in the south of the US with a long history of racism, the death rate for Blacks is currently 7 times that of whites. In every nation, those who will disproportionately die will be the poor, for a variety of reasons you will recognize. The poor live in more crowded conditions. They often lack family doctors and health insurance. So when they get sick, they wait until they cannot breathe to try and get hospital care. Their diets are not as healthy, so they often have complicating medical conditions when they get the virus. They lack access to soap and disinfectants, sometimes even water for frequent hand washing. They are less likely to have accurate information about the virus and safety precautions. They are less likely to have work that they can do from home. So during a lockdown, they're either without income from work, or they work in essential services in public where they are more likely to get infected. Also, in extended lockdowns, the poor without savings are more likely to starve to death. These distinctions between the poor and the non-poor are also predictable between poor and rich nations. Many poor countries do not have as many vents as one hospital in New York City has. But keep in mind that there are other considerations which also make a difference. As the virus dies down in many rich nations, unneeded vents are being sent to poorer nations. And although there are no treatments for this virus, much less a vaccine yet, doctors have learned now some things very recently that will help in these later stages of the pandemic. For example, it seems that a number of people who in the past would have either died if they didn't get a ventilator or been put on a ventilator can survive with a process called planing. And this is simply placing the patient on their stomach or on their side to facilitate breathing instead of laying them on their backs. Something that simple has been found to be sufficient for 10% of people who in the past would have gone on a vent. Also, a great deal in this or any other pandemic will depend upon the quality, the preparedness of the nation's healthcare system. What percentage of the people have regular access to healthcare? Now, I want to move to the allocation of scarce resources, the big ethical questions in the virus. The vast majority of ethical decisions around the virus are not governed by any absolute ethical rules, but rather involve a kind of calculus, a weighing of advantages and disadvantages. This is especially so around the allocation of scarce resources. If a hospital does not have enough ventilators for all who need them, what are the criteria for who gets a vent and may live, and who doesn't get them and certainly dies? In many nations, the issues will not be vents, it will be hospital beds. Will there be enough hospital beds and who gets them? There are various ways to decide. There is first come, first served. There's a lottery, or choosing the most socially valuable persons. All of these have been tried in various situations in medical ethics, and all have been found inadequate. Today, there is general agreement that a triage procedure that gives vents to those who are most likely to survive with a vent is the best. Doctors, of course, are not fond of this procedure, even though they recognize its fairness, because it falls on them to make the decisions about who lives and who dies, who gets a vent and who doesn't. It is hard to tell suffering patients or their families that because of their age or their heart disease or other condition, that they will not get a ventilator and will almost certainly die. In order to make these decisions, doctors must look at the existing statistics about who lives and who dies, and those are clear. Age and comorbidities are the predictors. although some doctors' decisions on ventilators using these criteria will seem very clear, as in choosing between a 70-year-old diabetic with hypertension and a healthy 30-year-old soccer player when neither of them can breathe on their own. There are always enough examples of contrary results to make a doctor uneasy. There have been cases of persons over 100 years old with underlying medical conditions who have survived the virus, and 20-year-olds with no medical conditions who have died. The lack of certainty about just who could survive with the event haunts doctors who are forced to make these decisions. If a hospital does not have enough masks and other safety equipment, who should get priority? Everyone can agree on the priority of doctors and nurses in COVID-19 wards. But after that, amongst hospital aides, hospital cleaners, laboratory workers, ambulance drivers, police, firemen, family members of infected people, grocery workers, many of these are the unsung heroes of the pandemic. In the US so far, as many ambulance drivers as nurses have died from the virus. And almost as many grocery workers have died. I have a niece and her husband who are both nurses who work in a COVID-19 ward in Phoenix. They are never sure when they arrive for their 12-hour shifts if there will be enough protective equipment for them. They need paper surgical suits to cover all of their clothes, covers for their shoes and hair, face masks to cover nose and mouth, and plastic shields that cover the entire front of their head. In normal times, with highly contagious patients, they would put on a new set of protective gear after interacting with each patient. But now, the set must last the whole 12 hours, even if and they may not even have all parts of it on every day. Most of the set gets destroyed at the end of the shift. The shields and masks are disinfected, and they go home. They shed all of their clothes in the garage into the washing machine. They shower with disinfectant. They put on clean clothes, and only then do they go to collect their 2 children, ages 4 and 1, from the special daycare center for children of essential workers. Despite such precautions, many doctors and nurses have gotten the virus and given it to their families. Dozens, many dozens have died. One last allocation issue that has come up in the US. There are no proven treatments, no drugs that are proven to treat COVID-19, but there are a number that are being tried. And one of the things that is happening is that some of those drugs, one of which is a malarial drug, another is a blood pressure drug, there are a number of them. Those drugs are being diverted to hospitals to try to test on patients to see if they can save more. And they are being bought up on the market by profiteers and other people. And persons with other diseases, lupus, diabetes, and other conditions cannot get their normal prescriptions of these drugs because the drugs are being tested and being stockpiled by others. So we have people who are dying because they can't get their normal medicines. Obligations to the institutionalized. 3 other groups of persons have been found to be at high risk, all of whom are institutionalized. Those in prisons and jails, those in detention centers or refugee camps, and those in nursing homes. In the US, we call institutions that care for the elderly who need nursing care, we call them nursing homes. People live in them. They're homes for old people who need special nursing, who can't be taken care of at home. In the US, though the numbers vary a great deal from one nursing home to another, about 1 in 5 nursing home patients has already died from COVID-19. In some states, this is half of the COVID-19 deaths in the state. We need more research to discover how the virus spreads in nursing homes, though there's a high level of deaths amongst nursing home workers, which may have something to do with it. The US has over 2 million persons in prisons and jails. In 2014, 18 states notified the US government that they were operating with more than 100% overcrowding. And most states have increased overcrowding since then. The chief methods of preventing the spread of the virus are frequent hand washing and social distancing, neither of which is easy in prisons or jails. In many states, soap is considered a luxury and is not supplied by the state. So unless relatives send soap, prisoners are unable to wash their hands. Social distancing is even more difficult since prisoners live in either 2 or 4 person cells, and the fronts of each cell have only bars, not walls. Thus, any infected person who coughs in the hall may spread the virus to as many as 4 cells. And if one person in an 8 by 10 foot cell gets the virus, all of them will. Ironically, convicts awaiting execution on death row are more protected because they have solitary cells. In the state of Ohio, 73% of inmates have tested positive for the virus. Many states and counties have done nothing at all to protect prisoners. However, some county sheriffs, aware that many of the prisoners in their jails are simply awaiting trial, they have not been convicted. They have released many that are accused of nonviolent crimes in order to reduce the prisoner population to 1 per cell. But that is not always possible. Many state prisons have done the same to convicted prisoners, releasing those whose sentences were due to end within 6 months, those who were over 60 and therefore at high risk from the virus, and those who had only nonviolent conviction. However, such decisions sometimes backfire, as when one young prisoner with no violence in his record was released in early April, and the same day killed his girlfriend who had turned him into the police. There was public outrage after that at releasing any criminals at all. In refugee camps around the world, there has been virtually no testing, and many have no hospitals, thus no ventilators. There are 10 million persons in refugee camps where there is no testing, where conditions may include limited access to water, soap, and even food. In the US, detention centers for illegal immigrants and persons claiming asylum have many thousands of people in large tents and covered wire enclosures, with testing limited to those who already show symptoms. The US government has stopped providing information on the virus in detention centers. Once a vaccine, I'm going to talk about preparedness now. As Aziz said in the introduction, preparedness for the next pandemic is going to be a big issue. Once a vaccine is developed to end this pandemic, the ethical issues that will dominate the global conversation will be none of these issues, but rather the issue of preparedness for the next pandemic. One of the scandals in the US has been that because there is no national coordination, states, counties, and individual hospitals have been competing with each other and with the federal government to buy scarce medical supplies, from masks to ventilators. And those with the most money win the bidding war. Countries have been bidding against each other as well. Inevitably, all this bidding money has brought out an army of international scammers who take orders and money for non-existent supplies. As I mentioned before, because they had experienced the 2003 SARS epidemic, Singapore, South Korea, and China had stores of protective equipment, dedicated hospital beds, and ventilators. They had plans for very quickly producing millions of tests for COVID-19 and had a plan for massive testing and follow-up tracing and testing for all who could have been infected. South Korea was so effective that it did not even have to lock down. No lockdown in South Korea. And yet they went through the whole process of the virus to the end very quickly. Germany did a lockdown that was so total that more limited testing and tracing regime was still very effective. It kept their deaths to about, they have a larger population than France, and France has almost 5 times the deaths that Germany does. None of the nations who were thus far most successful against the virus were among the poor nations of the world. But it is noteworthy that only Germany amongst the rich nations has so far been very successful, in part due to early lockdown and a population that reveres order. With hindsight, governments all over the world are already reassessing their disaster preparedness for epidemics that scientists now predict will reoccur on a regular basis due to human density and the interconnectedness of our world. Many nations have had stockpiles of food, water, and oil in order to cope with potential natural disasters, but have only planned for isolated local disasters from hurricanes, floods, earthquakes, volcanic eruptions, tornadoes, and droughts, not for national epidemics or pandemics. Only those nations who had experienced SARS were really ready for this. For poor nations, there is real debate about what level of disaster preparedness is appropriate, because all of the resources that are stockpiled against a possible disaster are resources that cannot be used to alleviate the scourge of poverty now. But it is clear that even poor nations can develop a plan and train persons at all levels to respond once an epidemic appears. Besides training, the foundation of that plan must be basic healthcare access and education throughout the nation. Situations differ from country to country, and not enough is known about the process of the pandemic in many poor nations to be able to easily make good judgments now. And it is not clear how well we will understand what has happened even after it's all over. For the situation in most countries is that there is not enough testing to know how many are infected with the virus, and no reliable counting of the death toll from the virus because so few cases were confirmed by testing. At the present time, in many countries, it seems that the most reliable death tolls from the virus are not from hospitals or clinics who treated those tested positive and report to the National Health Service, but rather from crude comparisons of the total deaths during these months with total deaths from these months in previous years. Just this morning, the Center for Disease Control in the US issued an announcement that in 7 of the northeastern United States, they had found that there were 9,000 additional deaths in the previous month, not attributed to COVID-19, but above the normal level of deaths. They think that that 9,000 additional deaths are a combination of people who died from COVID-19 without ever being tested, and Also, from people who died from other diseases or conditions, especially heart attacks and strokes, who would normally have lived, but they were afraid to go to the hospitals for fear of getting COVID-19, afraid to go to seek help for their condition, and so died. So we think that the numbers that we have now in every country are probably much lower than the real cost of the virus. And we will probably continue to lack data about how comorbidities, age, and sex affect the progress of the disease amongst the poor, because if any group gets undercounted and underanalyzed, it is the poor. This is one reason for some present anomalies. In Latin America, the nation with the highest case count and the highest death toll from the virus is Peru. Yet Peru has one of, if not the, best healthcare systems in Latin America. And it went to lockdown very early. Experts think that because it was more on top of the epidemic than other nations on the continent and has widely tested, it has a better count of the victims. And that nations like Brazil, whose president discounted the reality of the virus and refused to lock down for many weeks, have many times the reported number of cases. Also causing undercounts in many nations are political motives. Russia, for example, has reported relatively few cases, and many of the infected who die are counted as deaths from pneumonia or heart disease, which of course is the final cause, but it leads to a massive undercounting of the human toll of the virus. Nations have three choices when faced with COVID-19. They can do nothing. They can implement a massive test, trace, and test program, or they can lock down and do testing of those with symptoms. They can also combine test and trace with lockdown. In order to be most effective, the test, trace, test, and quarantine path must be done immediately. Once the virus is widespread, lockdown or do nothing are the only options. The general purpose of lockdown, however, is merely to flatten the curve, to slow down the spread of the virus so as not to overwhelm the hospitals and supply chains. But lockdowns will last for 3 to 4 months. Because what you've done is taken a 2-month epidemic and spread it out by keeping people apart from each other. But one must calculate when an extended lockdown leads to more deaths from starvation or malnutrition or other medical conditions that do not get treated than there would have been with no lockdown at all. And economists warn that once an economy is shut down, opening it will not restore the pre-virus status for many months, and perhaps not at all until there is a vaccine. Because stores may open, but many people will be afraid to go to them until there is a vaccine. There's also major questions about what should get locked down and what stays open. The United States is a tangled mess where the provisions of lockdown differ everywhere. In some places, tobacco stores and liquor stores are considered essential, and so they stay open. We have had a big, and you will appreciate this, we've had a big political to-dos here over some governors have insisted that religion cannot be locked down so that religious services can continue. Most governors have said this is crazy and stopped it, and even arrested a few ministers who have insisted on having their regular mass meetings. But one of the things that we have found is that in over a dozen cities in the US and in other countries, a mass church service or synagogue or a mosque service, especially in Iran, the mosque services, was the source of a major pocket of infections. Hundreds of people became infected following these meetings and infected many other people. Resistors in different religions tend to use the same arguments in favor of religion being an exception to lockdown. They say, God will protect the faithful. Governments have no right to limit the exercise of religions. And God sometimes demands that the faithful risk their lives for God. But infections have defied all of the religious leaders. And we have in this country many, many more dead because of the refusal of many pastors to close down their churches and shift to online services or TV services, as many have done, but the exceptions are terrible. Lockdowns must be near complete to be effective. Some nations, like Indonesia and the Philippines, have enlisted not only the police, but the military to enforce lockdowns. In those cases, much depends on how well trained the police and the military are in dealing non-violently with civilian populations, and how much the civilian population trusts the military. In some places, heavy-handed military could greatly add to the suffering of the poor. Long-term lockdowns, longer than a week, must be supported by massive food distribution programs. This is an issue for poor countries, not only the cost of the food, but the cost of reaching all the people who need food quickly. Inevitably, politics will play a part, with favoritism going to those groups who support the party in power, and even corruption, with food or money siphoned away from feeding the poor. The number of ethical decisions within and after a pandemic are immense. As you have heard throughout, we lack a great deal of information, and data collection will be critical as the pandemic surges on if we are to be any better prepared for the next pandemic. I would welcome your questions, and I apologize for the grimness of this presentation.
Okay, thank you so much, Professor Gutov. Usually we do clapping, but we can't do that now. All right, everyone. Now there are 100 people are in the room in the Zoom meeting, and there are 21 people are watching via YouTube. So it's quite big attendees, big number of attendees, and I will welcome people who want to ask questions or want to give commentaries. Yes. And there are 3 ways you can do that. You can raise your hands virtually, or you can do that via the chat room, or you can do that via the YouTube live streaming. You can write down your questions there, and I will read them for you. Now I will open this question session, and please raise your hands. So there is one from Pak Leo, right? Oh, Pak Leo, raise your hands. Let me unmute you.
Thank you, Mas Aziz. Yeah, thank you, Mas Aziz. Thank you, Professor Gudor, for very it's dim and bleak picture of our world today. But I think we knew that somehow, psychologically speaking, we knew that situation anyway. You just emphasize the fact and brilliantly connected with the ethical issues. I have only one question, Professor. That what can we say about leadership in the world, in the correlation with the populism politics that's growing, and many of the most careless leaderships in dealing with this issue are coming from the more or using or made use of populism in their politics? Thank you.
Okay.
Yes.
Do you want to
Can I answer?
one by one or three questions?
I'll do it very quickly. Okay. So
Okay,
one by one.
Yeah,
Okay.
we can do that.
Yes, it is. The most irresponsible behavior has been by populist governments. There is no question about that. And we find that within the United States. As you may know, our president falls into that category, and much of his party, not the whole party, but many in his party do too. Many Republican governors were dismissive, entirely dismissive of this virus, as our president was, as the president of Brazil and many other countries. And those countries will suffer because of that. They will not be able to control. They are not able to control the situation, and they will have more deaths. Yes, one hopes. One of the political issues that's very difficult here is that in many places, people will, in a crisis, support for leaders will increase. One hopes that, we saw some of that initially, support for Trump in this country went up when the virus started. But we hope that people who have failed to manage the crisis well will suffer for it in the polling booths and voting. Okay.
Okay. Is there another person who wants to ask? Please raise your hand so that I can see, because there are 100 people and it is a bit difficult to notice. Mbak Yuli. Oh yeah, there is a question here in the chat. Professor Gudov, what is your opinion on herd immunity? Herd immunity. So I think if we contextualize this issue in Indonesian context, the choices are quite difficult because there are restrictions, total lockdown, and as well as herd immunity. In fact, some local leaders, some governors have said about that, herd immunity, and what are the calculations in terms of ethical decision making that we have to take into consideration.
Well, herd immunity, there is some question about whether people who had SARS and survived may have some immunity against this particular coronavirus, not total, but perhaps some. And we have many people who will survive this, who will get a mild case and will survive. But herd immunity usually requires around 75% of the population to be immune. But do the statistics, in order to get to herd immunity, where 75% of your people have survived COVID-19, what is the death rate if 2.5% of people who get it die? The huge death rate to get to herd immunity. Huge.
So that should be something that has to be avoided, right? Or
yes, really. You don't want 75% of your population to survive this, because it means that probably hundreds and hundreds of thousands would have died. Perhaps more in your country, because I suspect you won't have enough ventilators unless you get massive foreign aid in time. Other question?
Other question is from Dr. Meridian, but I didn't see where is your hand? Dr. Meridian Alam from Brunei Darussalam.
Hello, Aziz. I'm here.
Yes.
Hello.
Yes.
Hi, Gudov.
Hello.
All right. Can you see my my face?
Yes, I see your face.
All right. So my connection here is quite unstable. Recently, I've been observing several anti-lockdown contentious protests that is happening in New York and also in Albany. So I read that the protesters, in nutshell, claim that this lockdown policy has been against the American people's ethical principle of autonomy, individualism, and personal space independence. So my question is quite simple then. How would the recent the state level stakeholders undertake in New York and other federal state to keep all of the safe preventive measures on track and to to calm down the public outrage to avoid the lockdowns? All right, because yeah, as you presented earlier that some of the religious leaders are condemning that lockdown is sort of breaching the human rights, like the
Mhm.
people are able to perform their religious activities, like in synagogue and even in the mosque, and even the ones who are Catholic in the church who are not able to go to their religious congregation. So how would then the this autonomy, individualism, and personal space independence could be a balance through the state level preventive measures? Because like
Yes, I
for
understand.
yeah. So because I have observed that in some of the democratized country, like even in Indonesia, not only in America, lockdown is it's wildly difficult for even the leaderships to, to instruct the citizen to stay at home. And even here in Brunei as well, the government has to deploy, like, the civil militants to control the citizens.
Mhm.
And we're also experiencing sort of like curfew every
Yes.
like 24 hours. And last time we also experienced like people were questions on the street because they're not practicing social distance and so on and so forth. So I think there is something like visceral effects of people in terms of their autonomy, individualism, and personal space independence to be, to be uh, considered in this case. Thank
Yes.
you.
Okay. Well, let me say about yes, we have protests in various states across the US, but you need to understand that in every state that has protests, more than 85% of the population supports the governor's lockdowns. So you're talking about a minority. And to be very frank, this minority of protesters in this country tend to be, well, they're Trumpites and they disapprove of anything the government does. He came into power swearing that he was going to drain the marsh and cut down government, and they don't want any restrictions on them at all. We see people like this when I go to pick up my medicines at the store. I see people that are not masked and who are defiant about it. Nobody's going to tell me what to do, they say. All right. We just have to put up with these people, and many of them will suffer the virus for their failure to observe these rules. Now, I think in poor countries and in poor parts of the US as well, you have to be very careful with lockdown, because people will not stay locked down if they don't have food. They will go out in search of food. So if you want to enforce your lockdown, you have to have massive food distribution, massive. I mean, we have in this country, I don't know if you've seen any of the videos, but in state after state where there are food distribution centers in the cities and towns, there are people that are lined up for miles, their cars for miles and miles every day to get food distribution. And when they're interviewed, they say, without this food, I would not eat. My family would not eat today. So those things, lockdown, enforcement of lockdown and food distribution have to go hand in hand.
Okay, there is another question, and can you still hear my voice?
Yes,
Because
I can.
it's a bit unstable also, my internet connection here. And Mas Anju, please stay alert if my internet connection is unstable. I'm going to read one question here from Valentina Wiji. Professor Gudov, what ethical assessment do you share on the scientists who do not guide towards the betterment of humanity based on the valid evidence and even spread the disinformation in this COVID-19 pandemic situation? For example, we are facing the tobacco industry interference here, and certain so-called scientists share the misleading information. So perhaps this about the information whether tobacco can
Yes.
minimize the risk of contracting
Yes.
the virus.
This is very interesting. I don't think that we can condemn that yet. There is some anecdotal evidence about this, some analysis of statistics that says that perhaps tobacco can provide some immunity. Right now, France has organized a large double-blind, you know what a double-blind study is. It means that some people are, everyone is equally exposed, and some people will be smoking tobacco and some people will be smoking something else. It's actually a test of nicotine. I'm not even sure if they're smoking it. They may just be using nicotine patches, but they're testing whether nicotine provides any immunity. We don't have the results yet. I tend to doubt it myself, but we don't have any final evidence yet on this. But there have been, at the beginning, particularly of this pandemic, there were a number of people with scientific training who should have known better, but their politics got in the way of their science, and they minimized the threat of the virus, and that had terrible effects in many parts of the world. But I think most of those people are now quiet. I mean, we have also some of the strangest things. I was reading the other day that one of the major imams in Iran instructed his people to soak a cotton wad in, I forget what kind of oil it was, peppermint oil or something like that, and put it in their anus, and that this would protect them from the virus. I mean, this is crazy. This is crazy. But so there are a lot of people out there with bad, incorrect, and self-serving cures or preventions for COVID-19. We have to always be on the lookout for that.
All right. Another. Until when this? Perhaps we can have this discussion up until 10 and 15. Yeah. Here in Jogja, I mean. Another question from Alfredo. Hello, Dr. Gudov. My name is Alfredo. Thank you for your presentation. In times of this pandemic, the precarious workers have been suffering from either a lack of consumer or being part of vicious mode of production. What do you say is the ethical burden and the difference between the large and small businesses? For example, very large businesses such as Amazon are owned by the richest person in the world, not giving them paid leave and also not providing the necessary safety. So I think it's about what should be a company's responsibility for their workers.
Yes, we have had a number of areas of the economy where workers have charged that they are not given proper protection. Right now, and Amazon was one of them. But right now in the United States, the big issue is meat processing plants. 22 huge meat processing plants, you know, where people take pigs and cows to be butchered and and put into packages to sell in grocery stores. Some of those plants have thousands of workers, and 22 of them have been shut because so many of their employees have contracted the virus and some have died. And the president has just said he is going to order them to open. And there is a real question. Can you order people to work when it is endangering their lives? And there's huge debates about that going on here. I mean, right now we have no shortage of food, but they're using the threat of shortage of food to try and force workers back into conditions that are very dangerous. Many of them were never given any protective equipment. And the fact is that on the assembly lines where they cut up the meat, they're so close that social distancing would mean cutting way, way down on production. And it would mean redesigning the lines, the assembly lines. So this is a big issue. The other thing at the beginning of what you said, small companies and big companies, and in the United States, the big bill to provide cash to help small businesses, all the money, or virtually all the money in the first tranche went to big companies, not the small companies that it was intended for. Some of the big companies are now rather ashamed of that and are giving the money back, a few. But the fact is that many small business owners have not gotten anything of this trillions of dollars that is being put out there to stop the financial effects of this. Most of it has gone to big business. And that's wrong. I mean, I hope that's clear.
Okay, Mas Aziz, you there?
All right.
Yeah.
Yes, Mas Anju.
So we have some question here
Mas,
from.
I want some say.
Yeah, we have some questions.
Go ahead.
3 questions, I think, here in YouTube too. So let me just read them for you too, Professor Godorf. So the first question is from Teresa Rida. Hello, Professor. Thank you for your insightful lecture. I was wondering, what is your opinion on the idea of refusing lockdown to save economy? So it was quite popular here in Indonesia for some time now, because of the economic reason, for food. They refuse it. They cannot live their life without having food, and so they refuse the lockdown. So what is your opinion on that?
Well, the difficulty is that most places went into lockdown because this is what the health authorities suggested that they do. But the problem with lockdown is that it only works if it is long-term. And so long-term creates huge economic problems, particularly for the poor who don't have savings. And so need food. That's why I said that lockdown has to be connected. If it's going to be enforced, it has to be connected to massive food distribution. Otherwise, it's unjust.
Okay. Yeah. Very difficult.
Yes, very difficult.
Another question. This is also related to the US situation. Professor, this is from Tiffany Handoko. Professor, I would love to know your opinion regarding the actions of the United States government that was at first in denial with the severity of the pandemic, and why were they in denial in the first place?
The reason they were the government was in denial was because our president is stupid is literally, do you know that the latest scandal with our president is that he was running on at one of his press conferences a few days ago and suggested that perhaps people could inject disinfectant into their bodies and that would cure the virus. And of course, all the health authorities immediately sent out, no, don't do this, you'll kill yourself. I mean, he's crazy. He has no idea. His only interest is in, well, basically his only interest is in saving the economy because he thinks that will get him reelected. And so we constantly have, he stands up 5 days a week. He does this press conference on the virus, on how things are going. And his science people stand behind him and you can watch their faces. He'll say things and they'll go, because it's so bad. He doesn't understand. He didn't like it, and so he just said it didn't exist. That's his way of dealing with things that he doesn't like. It's fake news, he says.
Like, why did he do that? Like, why he keeps doing that? Like, is there any explanation?
Yes,
is it for, like, for political purposes or?
Well, there's political purpose behind it, but there's also, and he wants to get elected, but also he has a problem with recognizing reality. He thinks that if he says something and he wants it to be true, that it is true. I mean, constantly we have, and that's why he thinks that that any news organization that doesn't simply repeat what he says and broadcast him, if they do any analysis at all, he calls it fake news because they end up correcting his mistakes. He's never made a speech in which he didn't have a number of untrue statements that others have to correct. No, I don't want to say anything more, but just right now, the governors have taken the reins of this and ignored what he said. A few times he said he will decide when the lockdown will end, and the governors came back and said, no, the governors will decide in their own states when the lockdown will end. So he really doesn't have much, nobody looks to him for much anymore in this crisis.
Yeah, that would be a good lesson for us, like all over, like all the leaders, to learn about dealing with the lockdown. The last question from YouTube is from Dikonia Tarigan. Professor Gudo, what is your opinion about the opening of the data related to the number of infected or death rates, as like opening it to save the society or closing it not to reveal the real number in order to save the society?
Well, this is becoming a bigger and bigger issue. For example, I said in the United States, the government has stopped giving the number of cases and deaths in detention centers because there would be opposition to that. And many countries are not, for example, in the beginning, most countries and states here would give the daily death toll and you could follow it from day to day. Then they stopped giving that. And you can still find it in some places, but it's not on the regular news. And there's two reasons for this, and that's kind of an argument back and forth. On the one hand, you don't want to present really bad statistics that will panic the population. Nobody wants panic, mob action. On the other hand, if people don't know how serious the situation is, they won't take measures to protect themselves and others. So most governments have been trying to take a middle line of convincing people, yes, it is very serious, but not panicking them. But there comes a time when it's almost impossible to avoid. For example, in this country, at the height of the crisis in one state after another, there were not enough mortuaries to take care of the dead. The bodies of the dead stacked up in coolers all over the place. Okay.
Okay.
Okay, go ahead, Mas Aziz.
Pak Zen, do you have some comments?
Yeah. Hello, Bugudorf. How are you?
Hello.
It's very nice to see you again.
You too. You have gone gray.
Yeah. Oh, yeah. Yeah. It's been many years. Okay. So, yeah, I have. I've been thinking about this situation. I mean, like in this situation, people speak about science and anti-science policies, attitudes, beliefs, etc. People who reject social distancing or masks, for example, especially religious groups or government officers, they are accused of anti-science. We have writings, even in Indonesia, about that, using the term anti-science. But I'm rather hesitant to use this term. I see two problems here. First, there is the issue of uncertainty of science. I don't say that the science is so uncertain that we cannot make scientifically based decisions, not at all, but we also need to remember that the choice of lockdown, isolation, that's a really difficult question. And it is not simply a scientific decision. It is also a political, ethical decisions. And for believers, for religious believers, surely this is a really huge issue. I mean, most religions, I think, are communal, and exactly what is being demanded here is that they get rid of these dimensions of religion. That's one reason. So, well, despite thousands of years of religions adapting to different situations, but this is still a big issue. And secondly, it's also, I say it's rather strange, or probably not strange, I'm not sure, that the camp of science, I mean, if we use science and anti-science, is also occupied by those who stigmatized certain religious minorities. We see this very clearly in India, very badly. I mean, sentiments against Muslims were rising exponentially. Of course, there were already Hindu-Muslim tensions, but also actually, I saw this in Indonesia. I mean, it's too easy. People stigmatize certain religious groups as anti-science, for example. I didn't say that in this case that science is to blame. Of course, we need some kind of science literacy, but again, this is a difficult ethical, political questions that need to be considered, and sometimes people go too far, I think, using this term. Well, like just to give you one example, in Indonesia, there was a threat to the Ahmadiyya community, for example, when they do their rituals in the mosque, and they use this reason of well, these people, they don't know, they don't want to do social distancing, etc., and then they were stigmatized further. So I'm just interested to hear your comments on this.
I think any kind of crisis like this will be used. It will be manipulated. I mean, we see recently that many governments around the world have used the pandemic as an excuse for extending their control, their authority. Unlimited control in many countries has been given to the executive to deal with this. And it's not clear that that was necessary. And we don't know to what ends it'll be used. I think inevitably in something like this, for example, infections have always been blamed on the minorities. When you look back at we call it the Spanish flu in this country in 1917 and 18, killed 2.5 million people around the world. but it wasn't Spain. It was, and we've seen this again and again and again. People will use whatever the crisis is, the current crisis is, to attack their traditional enemies, the religions and the races that they don't like. I think it's inevitable.
Okay, Pak Zen, is that enough? Yeah. Now it's 10:20 here in Jogja. We still have 10 minutes, and there are 2 questions on the chat, and this should be the last questions that will be answered by Professor Gudov, and then
Okay.
yeah, we cannot do this forever, right?
Right.
Okay, first from Harriet. Hi, Professor Gudov. I'd like to ask about medical ethics in a situation like COVID. Who decides what the ethical protocol should be in cases such as ventilator shortages, for example, and deciding who gets the ventilator or choosing who will be trialed for vaccines? Is there a central body in the US from the government, or it is given to the discretion of medical workers? That's one first question. And another question, I would just like to know your take on the shortcomings of the Javits Center of New York in its efforts to serve as a temporary makeshift hospital in order to relieve hospitals of the mounting COVID patients. What could or should be done by other governments in order to maximize the utilizing of makeshift hospital and recovery stations? Yeah.
Okay. The people who make the decisions about ventilators are the doctors. Sometimes it will be an individual doctor. More often it will be a group of doctors in the hospital. There is no time, literally, there is no time to take these decisions to any other bodies, higher bodies. And it has to be done on a basis of looking at this patient. How old is this patient? What is their general state of health? Do they have hypertension, for example, which is the biggest comorbidity, most often causes death in COVID patients. So you look at the 2 patients and you evaluate all these things, and the doctor then will decide based on these medical conditions. The general strategy of this, which is a form of triage, this is agreed upon across hospitals. Okay, now that is not to say, I strongly suspect that if you are, for example, a member of Congress or on the cabinet of the President of the United States, you might have a number of comorbidities and you probably will still get a ventilator because power talks. But most of the time, for the rest of us, it will be the medical condition that will decide who gets and who doesn't. And the other about the Javits Center, well, the Javits Center is going to be closed down at the end of this week because the number of new cases has been steadily, and deaths has been steadily dropping in New York. Both the Navy hospital ship that has been docked there and the Javits Center, and I understand also the tent hospital in Central Park are all being shut down because the cases now have shrunk enough that the hospitals themselves are able to handle the load. The bigger issue is when hospitals will again take on elective surgeries, when they will go back to doing their normal things, because there are many people who have been waiting for surgeries now for months. And some of them, it wasn't an emergency, but for example, if they needed a new valve in their heart or stents in their coronary arteries, it can be dangerous to wait, and they've had to wait now. So that will be the sign of real returning normalcy. The first piece is the closing down of these makeshift hospitals. The second piece will be returning to do ordinary medical care. Okay.
Thank you, Professor Kutov. And I think for the last kind of closing statement that we can have here, and because we are here studying religion at CRCS and ACRS, I think the last comment would be something like, what is or what should be the role of religion in facing the pandemic? You can do it in descriptive manner or in the normative
Yes.
one.
I think we have seen that as every other aspect of our society has had to adapt to the virus, religion has too. I mean, we have scenes in this country of priests and ministers giving the last rites to people in nursing homes and hospitals through glass windows from the outside. We have the use of electronic media to bring people together for services. For example, Xoom is being used for services so that people can respond. You can share the parts of the service, parts of the readings amongst different members. I think religion has to be able to adapt in those ways. And there has to be a way that person-to-person ministry can continue through this. The toll, the psychological and spiritual toll that the crisis has taken on people, on millions and millions and millions of people around the world, is just tremendous. Yesterday, we had a very sad story of a doctor, an emergency room doctor in New York City, who has been working 12-hour shifts for months now. She committed suicide. And there's now a tremendous effort to try and support, give some spiritual and psychological support to these people who have been on the front lines for so long. But for those of us at home too, we need this. One of the scary things across Europe and in the United States is that we think that child and spouse abuse, the domestic violence rates have skyrocketed, that because people have been confined in their homes and they're under stress. In the United States, calls to report child abuse have decreased by 85%. And we think that is because in the past, the majority of reports have been by teachers. Teachers aren't seeing children anymore, so they aren't able to report it. So the need for spiritual support is immense. And religions have to do an even better job of providing that through the means that are available.
All right, thank you so much, Professor Kutov, we are really grateful for your willingness to share your perspectives. And everyone, if you want to clapping now.
Unmute them all. Unmute them all.
Well, I'm going to end the live stream first, so that mark to finish this forum formally, and then after that we can have 10 minutes for informal conversation. Okay. Right. So everyone on YouTube, everyone in the Zoom, we really apologize for you if you ask questions, but I cannot accept it because our limited time and the people who are going to enter the room, but it's already full 100 people. So announce it on our social media. Please follow our social media so that you can get any event, not only Wednesday Forum, but also other events held by CRCS in the future. So I'm going to end the live stream on YouTube, and you can have informal conversation from